Hello, everybody. I'm very glad to be here, and I'm very glad, and I would like to thank to organizing committee to invite me to provide some thoughts about access to treatment in Central and Eastern Europe. Sometimes it's very hard to generalize things between different countries, but I will try to do. Yeah, wait a minute. Yeah, thanks. Sometimes it's quite difficult to gather all things together with the different countries, but I'll try to do my best to show you the things happening in quite large area. What are the main issues in myeloproliferative neoplasms treatment? We have differences in treatment goals according to disease. We have the issue of so-called young patient. It is to certain dispute what does it mean young patient, less than 40, less than 50, or less than 60. But nevertheless, that's one of the questions asked by medical community, but also by the patients. We need efficient treatment for the first line for the common problems from thrombocytosis, from splenomegaly, elevated white blood cells, anemia. But we need also a good approach to a second-line treatment, meaning treatment of complications, vascular treatment, vascular complications in myeloproliferative diseases. But also I would like to point, and that's very essential, that all myeloproliferative neoplasms are orphan diseases. That means they affect 1 to 2 patients per 100,000. That means in our area we have only about 10,000 patients a year as a newly diagnosed. That's a small number comparison to countries we are representing, but it's, for those patients that's a main problem in their life and their work. What to say about young patients? Just you can see 12% of patients with polycythemia are younger than 50 years. Are they different from others? But when we are moving a little bit over, less than 60 is 1/3 of patients, and it's a bulk of patients with polycythemia. On the other side, we know that one of the main problems with myeloproliferative neoplasms are thrombocytosis at diagnosis and during the disease. When we are putting a bar of 600,000 platelets, we have more than half of patients with thrombocytosis, offering a problem for possible thrombotic event, and we should prevent it. On the other side, one of the main problems of patients is splenomegaly, and almost half of the patients have some kind of splenomegaly with possible growing during the disease. And luckily, but not always to say luckily, only 1/5 of the patients has previous thromboembolic event. But combined together, patients, age, platelets, spleen, we have a lot of problems, and we need a lot of different ways to tackle. In essential thrombocythemia situation is quite similar. Similar number of patients has a previous thromboembolic events. Aggressive platelet count over 1 million is present in almost 1/2 of the patients, and 1/2 of the patients, 46%, is also older than 60 years of age. That means have a certain comorbidities and possible vascular risk. So, who we are? We are the bulk of predominantly small countries. The largest one is Poland, and the second one is Romania, and we together, without Russia, are like United Kingdom, France, and Germany. But incorporating Russia, we are at the size almost of United States. Are we wealthy? No, unfortunately. In comparison to classical Western countries in Europe, our GDP is about 1/half. Sometimes those countries have a problem with obtaining enough money for the health insurance funds. Especially, health expenditures are very high in countries of a classical Western Europe, and our highest devotion is about 2,000 euros, 2,000 international dollars per capita in Slovenia. In general, we are selling and we are spending 3 to 5% of GDP for the health expenditures at whole. That means our patients have to struggle with the completely different health issues like cardiovascular diseases and other oncology. What is common within our countries? We have several common things. One, mostly centralized health resources, especially in hematology. In many of our countries, there are several referral university hospitals with expertise, with a bulk of good educated hematologists, with a lot of connections and education, especially from countries around. We have the possibility to follow up patients by the experts in the field, people who are devoted to certain area of diseases. Myself, I'm treating patients with myeloid malignancies, meaning chronic myeloid leukemia, myeloproliferative disorders, and MDS. I'm not a lymphoma people. With some exceptions, we have very centralized health insurance funding. That means we have a one government-ruled or government-designed health insurance fund with different budgeting policies. And unfortunately, that health insurance fund can also have the influence of politics or Ministry of Health. In most countries, reimbursement is fixed and it's a part of a negotiation of the government and health insurance fund with pharmaceutical companies. And of course, we also work on evidence-based medicine and guidelines and recommendation-driven treatment. We're trying to follow the rules because our resources are not limitless, so we can be aware that we can provide as much as we can to our patients. What we have in current treatment? We have a good drugs for control of cytocytosis, like phlebotomies, hydroxyurea, busulfan, anagrelide, and even interferon. We have drugs for control of splenomegaly, hydroxyurea, interferon, and in the last several years, ruxolitinib. We have drugs for treatment of constitutional symptoms. We have drugs for treatment of thrombosis. We have also abilities to treat and tackle patients with anemia. Unfortunately, some of those drugs are off-label, and we have a lot of problems in many of our countries, especially because of that non-labeling. What is our patients facing? Sometimes they're facing that they have problems with insurance. Not in general with insurance, because all patients in my country with the malignant diseases have insurance. But myeloproliferative disorders are not malignancy at all. They are not C code in the classification of diseases, but D. That resembles a lot of problems because they cannot always have full insurance. Drug is unlisted, very common. There are a lot of drugs which are unlisted or are reimbursed. Sometimes we do not have some drugs available in other countries. And of course, we have the lack of expertise by doctors on a regional level. Luckily, in many countries, the patients have been directed to larger centers. One of the main leaders in creating some kind of recommendations, the European Leukemia Net Working Party on Myeloproliferative Disorders. And in the last 10 or 15 years, they have performed a lot of work and creating 3 times recommendations about diagnosis and treatment of our patients, and it helps us a lot because we can direct ourselves to things which are the most needed in our countries. And almost all countries in Eastern and Central Europe are members of ELN working parties. So, we have some issues. Can we follow the recommendations? Well, we can say yes, but we can say also no. Current recommendations by ELN Group decided and providing a suggestion of selection of the drugs for the first and second line treatment. There are some problems with that. In PV, they are recommended to use hydroxyurea or interferon as the first-line treatment, special interferon in younger patients. That opens issue, what are the younger patients, less than 40, less than 50. In my center, we are providing interferon to patients less than 40, 45, especially those who do not have kids. But interferon, as you know, from the first day, in any forms, is not officially registered for myeloproliferative neoplasms at all. For the second line, ELN recommends use the alternate treatment, but there is no current recommendation about the use of ruxolitinib in patients who are resistant to hydroxyurea, and there is no any recommendation to use ruxolitinib in patients not active, not doing well on interferon. And there is no also clear concern about use of pegylated interferon, and we are waiting probably new trials and the new data on it. And some of the large groups in Western Europe are trying to do that, especially French. In Italy, the situation is a little bit similar. We have also a recommendation to use hydroxyurea or interferon is the first line setting. Again, interferon is not registered. ELN panel did not reach the consensus about the use of anagrelide in a first-line setting. And we have two labelings, and it's very frustrating for people who are living outside the European Union, that anagrelide in countries like England, France, Netherlands, United States is a second-line treatment after the failure of hydroxyurea based on PT1 trial. On the other side, based on anhydride trial performed in Central and Eastern Europe by Austrian group, Professor Gieslinger, it is recommended and it is registered as a first-line treatment for patients with high-risk ET, high risk of thrombosis. That means what is the way? One way as a second line or the other one as a first line. In countries when they have many insurances, it's not a problem because the insurances will help decision. But in our countries, it's very hard to provide information and to fight for the drug. So anagrelide in Serbia is not officially reimbursed, but some patients, according to certain legal procedures, can receive the drug, but not the majority who need. Also, ELN panel recommends strongly aspirin. Recommends aspirin as based on several large-scale trials. But there is no any simple word about any other antiplatelet agent used in a current medical practice, from clopidogrel to ticlopidine, etc. And there is no any other issue and comment on something which is very common in general practice of internal medicine, meaning aspirin resistance. We have a lot of people taking aspirin because of cardiovascular diseases, and we have a lot of papers, a lot of recommendations by cardiology societies to measure aspirin resistance or to measure aspirin effectiveness. There is no current suggestion by ELN how to tackle with this issue, and it poses a problem because you have a patient who went to his GP and he said, "Oh wait, why don't you change the drug? It's only aspirin. Why don't you take clopidogrel because it might be more potent?" So I made some small survey just to see what the things are doing in Central and Eastern Europe, and I have taken countries from EU and countries also from the Balkans who are candidates for EU. In almost all countries, we have hydroxyurea. In all countries, hydroxyurea is also reimbursed except in Bulgaria. On the other side, interferon is available in some countries regularly, even it's off-label treatment. But in some countries, like Czech Republic, like Croatia, like Montenegro, Macedonia, Serbia, interferon is available for special paragraph, special legislation, and it's not widely used. We have anagrelide also in some countries with a wider and in some countries with a narrow indication. That means anagrelide for all patients with thrombocytosis or in patients only with ET. We do not have, in general, pegylated interferon, and it's a part of the clinical trials, possibly. And we also have ruxolitinib for some indications, but in some countries, even for polycythemia. When we are searching for the number of clinical trials, we can see the clear cut from the east to west. Only few clinical trials are performed on the countries on the east. Probably there are many reasons for that, but it's not our expertise. We are open and very welcome. As I said yesterday evening, we are open and very well trained to lead the clinical trials. So what can we see in a crystal ball in the future? We can see probably that the number of the clinical trials in our countries should be at least double. We are very looking forward to have an investigator-initiated trial as well as a possibility to exchange our medical knowledge with the colleagues from the other countries. There are also interesting fields with the new ideas like supportive treatment, treatment of anemia, anticoagulation. Nowadays we have direct oral anticoagulant treatment, which are much safer for the patients, much easier for them than classical anticoagulant treatment. Also the use of platelets. All those trials need a lot of patients, and those patients are on the east. How can we improve our treatment? The understanding of the biology of the myeloproliferative disorders in general led us to many new ways of treatment. I recall with Dr. Mesa yesterday afternoon that we met each other 15, 16 years ago on one meeting with experts in MPN. And from that time, we have no many moves towards the better treatment. We have much wider use of interferon. We have ruxolitinib. We know about the JAK, but nothing more. We need a current change of drug labeling. We need a change of our local legislature, and that's one of the tasks of the patient societies. We need international cooperation. We need education of all other doctors. What are the goals? One of the goals is to improve survival, because survival on the ENT is very near survival of the patients of the people in the general population, but the survival in polycythemia and myelofibrosis is less prominent. Do we have armamentarium? Yes, we have seen a lot of various drugs. Probably most of those drugs will enter into market or will enter into phase 3 clinical trials. We probably need new targets. We probably need a different approach. We need probably combinations. And in the moment, companies are not very willing to perform combination trials. Now we have trials just with ruxolitinib and combinations. And on the other side, we need affordability of the drugs, because the high price of the drugs is also one of the obstacles that in many countries of Central and Eastern Europe, patients do not have regular access. And of course, what about leukemic transformation? Only 10 to 15% of patients with MPN can progress into leukemia. Unfortunately, most of those patients could not be treated properly because of age and comorbidities. We have certain treatment which can be better, like azacitidine, decitabine, but also there is a combination of liposomal daunorubicin and RSC available nowadays from the clinical trials and entering into market very soon. And we have very nice and very efficient treatment like anti-BCL2 inhibitor like venetoclax, very famous in CLL. And you can see this is a BCL2 of the patient with blastic crisis of primary myelofibrosis. Again, good target. So we have bone marrow. We can do it as a salvage to our patients. And I believe there is a dawn of the new era and new hope in myeloproliferative diseases, even in our countries. Thank you.